Simulation Happy Hour acknowledges the land and the waters from which you are listening today. Welcome to Simulation Happy Hour. Sit back, relax, and let's talk about all things sim. All right, welcome to another episode of Simulation Happy Hour. And returning again, which we're very excited about, is clinical professor Kate Morse, who is the Assistant Dean for Experiential Learning and Innovation at Drexel University, and Mary Fay, who's the Associate Director of Applied Learning for Performance and Safety with the Center for Medical Simulation. Welcome back.
Thanks for having us back, Mel.
Thanks, Mel.
And I'm joined with Kerry. How are you going, Kerry?
Yeah, hi, Mel. Great to be back here. And as I just said, last week I'm looking at you in the US, and here you are back in Australia with our wonderful US colleagues. So fantastic. I know our US colleagues are virtual, but great to have them on board again. Love it.
Absolutely. I am wearing my Washington, D.C. jumper. So there we go.
Oh, very nice.
Okay, well, I'm so excited about the topic today. So we're talking about SimZones, and in particular about applying it in different settings. So we all work in higher education, so we'll go to there. But initially, I guess for those people that aren't familiar with SimZones and what it is and how to apply it, Mary, I'm going to start with you. Can you help explain what SimZones is and where it originated?
Sure. Happy to, Mel. So SimZones came out originally from Children's Hospital in Boston. And the original paper was Chris Rusin, our colleague at CMS, and Peter Weinstock. From there, and what really happened was Chris hadn't worked in healthcare before. And then he came into healthcare and was working as a simulation director at Children's National Medical Center. And he looked at the simulation that was going on and he thought, oh, there's different kinds of simulation that require differences in approaches and resources and faculty roles. And what is so blindingly obvious after you read the SimZones paper is just that. But I think the brilliance of Chris Rusin is that he sees patterns and he sees structures and he names them so it makes them accessible. And so that's really what SimZones is. It's a framework for a couple of different things. It's a framework for the development of a simulation curriculum. It's a framework for thinking about resources needed by a simulation program. And it's very much, we're going to talk about this a little bit later, it's very much a framework for faculty development in thinking about what you need to train your faculty to be able to do to facilitate the different kinds of simulations. So that's kind of high level where SimZones came from. And so as Chris described the original zones, there are 5 of them. There are zones 0, 1, 2, 3, and 4. Very briefly, zone 0 is instructor-less simulation or simulation that's done via some sort of an app or an online learning system where the students engage in some sort of educational activity and get some sort of feedback. So an example of that might be when students are practicing CPR and they get feedback from the mannequin about the rate and depth of their compressions. That would be a zone 0 simulation activity. And then zone 1 follows zone 0. And in zone 1, a learner is practicing just an isolated, context-free skill. And so it might be something like, as I think about nursing programs, putting in a Foley catheter using a task trainer. So there's no story around it. There's no context. There's just a task trainer on a table and the student is working through just the psychomotor skills of like, where do I put my hand? How do I pick up this piece of equipment? Because what we're really thinking about there is how do we keep their cognitive load low at this point so that they can just get the skill piece down. And then once they've mastered the zone 1 level, then they can move on to zone 2, or as we think of it now, they're ready to move into zone 2 because readiness planning is sort of another concept related to SimZones that helps us think about, are the students really ready to progress? So after zone 1, they move on to zone 2. And so let's imagine if we keep the Foley catheter example, that now the students are in a more full-scale simulation where there's a patient that they're interacting with, maybe a family member, and at some point in the simulation, a decision is made that a Foley catheter has to go in. So now they have to put that Foley catheter in with all the contextual features around their patients they have to explain things to, families they have to explain things to. It's not just a task trainer on a bed. Now it's a patient who's in a bed, with limbs and all that they have to think about. That's zone 2. Zone 3, then, as Chris originally described it, is zone 3 is when we start to think about how do we bring together the interprofessional team to give us opportunities for collaboration, but especially to help us explore what the challenges are in a given situation. Let's stick with the Foley catheter situation. Maybe the way we introduce complexity in a team into that is now the students have to collaborate with the interprofessional team to decide, is a Foley catheter appropriate? Could we just do an in and out catheter? When's that Foley going to get put in? How important is it? When does it come out? So you take into account now the larger issues around Foley catheters and their insertion. And then zone 4 is actually learning from real life. So technically not simulation, but we think about that more as clinical learning, but still with coaching and feedback that goes on as it would in any sort of workplace learning, workplace assessment environment. So that's sort of the big view of what the SimZones is. And I know what you want to talk about next. And so I'm just going to say, and so, as Kate and I started to think about what does this mean for higher education? Is it the same? We started to realize that there were some important differences. So the basic structure still stands, but the nuances within the different zones, I think, are a little bit different within the academic environment.
Great, thank you. I know at CMS, so that was originated within the healthcare context, so hospital-based simulation.
Right. Mm-hmm.
I know you've thought about this within your courses at CMS, so which is not hospital-based, it's classroom and in the sim lab. So how are you applying it in a course?
You want me to take this one, Kate? Keep going.
Sure. And then I'll add on the nuances of how I've incorporated into the master's course on simulation.
Okay, great. So, as I mentioned before, SimZones is really all about readiness. It's about ensuring that our students are ready to be in the learning situation that we're putting them in. And so it's really thinking about, what do they need to just know? Because there's basic knowledge you have to know before you can do something. So what do they have to know? That's kind of that zone 0 space. And then we start to introduce the skills gradually and add more context as we go across the zones. Mm-hmm. And so in our week-long instructor training course at CMS, as many people may know, what we're focusing on is teaching people how to facilitate and debrief simulations. And so within debriefing, there's the structure of the talk, there's the conversational strategies we use. And so as we do it in the week-long course, we have a didactic module that might be about using advocacy inquiry. And so there's zone 0 training in that is what we tell them about advocacy inquiry, why it works, what's the structure of it. There's zone 1 training then is we might put up a picture and say, create an advocacy inquiry question around this picture. So there's no context, there's no pressure. They're just looking at something and trying to arrange the words. Then we move them up to a zone 2 training where we show them a video with some students in a simulation. And now they have to ask the question to a human being. We'll have someone else in the course play the character in the video. And they have to now do an advocacy inquiry question to a real person and hear an answer. That's sort of their zone 2 training. And then we move them up further in complexity by having them then debrief a simulation using advocacy inquiry within the structure of a 4-phase debriefing conversation. And so that's how it is throughout the course with regard to conversational strategies, with regard to structuring a 4-phase debriefing discussion, and even a little bit around assessment, which we do some in the course. But it's really all about what do they need to do, have them get a little bit of practice with it in a decontextualized way with no pressure, increase the cognitive load now by putting some context around it, and then increase the complexity even more by putting them into a realistic situation. So we structure the course according to the SimZones too.
Mm-hmm. Thank you. And when you were talking, there's so many underpinning theories to that. It's all about constructivism and, zone of proximal learning.
Vygotsky, yeah.
cognitive load theory. And so, yeah, that structure is underpinned by a lot of educational theory.
Yeah.
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 Mhm.
I have to agree with you. Absolutely. And I think one of the most important ones you mentioned, Mel, is cognitive load. And I've seen that play out in nursing education a lot when people are not thinking about it and they drop students into a full scale simulation when they haven't had time to really nail down the component parts of it. And then the students freeze and get a deer in the headlights. And the faculty can't understand why can't they just do this? Well, because their cognitive load is too high and they just can't think. And so I think that's why the idea of readiness and making sure that students are ready to move into the next zone is critical. So yeah, I think cognitive load is hugely important there.
Thanks. And
Mary, just to double click on that, I fully agree. The cognitive load cannot be underestimated. And I think hand in hand with that goes the idea of skill decay, because I think that is such a challenge in higher education. Someone is taught a skill, whether it's putting in a Foley catheter, to use Mary's example, in fundamentals nursing, and then there's the magical thinking that happens that everybody's getting to do this in clinical practice, which we know is highly variable. And then when they come now to do it in a simulation, in a zone 2 simulation with contextual elements, a higher cognitive load, they've lost that skill because they weren't for an expert to lose a skill, we have a slightly slower slope, but for a novice gaining a skill, they have quite a rapid 2 to 3 2 months, they're gone. It's gone,
Right.
and they sort of, I always tease them, they have hotel memory. Somebody new comes in, somebody old has to leave because they get so much information. So if there's no contextual practice, it's not in their long-term memory to go back to it. I think SimZones is so helpful to be able to say to faculty, how do you know the learners are ready to be in this sim? And they're like, oh, well, they learned this skill. Great. When was that?
Yeah.
Oh, it was back in fundamentals. Okay.
Right.
And now we're like 3 semesters away from that. And when did they deliberately get to practice that with feedback?
Mm-hmm. Right.
Oh, yeah. So do that and then come to sim, and then your learners are not going to be stuck in, as Mary said, deer in the headlights, overwhelmed, feeling like they're not going to be unsuccessful. And your conversations are not going to be task oriented because they're good at the task. And they're looking at the more, contextual elements of what are they noticing, how are they interpreting information, if we're talking about nursing, what are they interpreting, what are they anticipating, versus, hey, we're going to spend the debrief talking about how you hung blood.
Yeah.
Important,
Yeah.
but not really what you necessarily want to get out of that debrief.
Yeah.
So I think that simple question of SimZones being able to say to faculty, how do you know learners are ready to be in this zone? It can be transformative to them because they're like, oh,
yeah,
oh yeah, I guess that really was in year 1. Yeah, then let's practice that before they come so they can now apply it in context, and we can talk about the bigger things about prioritization of care.
Mm-hmm.
Call in for help, whatever the contextual elements are.
I love that. What do you think, Kara? I love that concept about readiness for practice.
It so makes sense. It so makes sense. And to me, it's a great way of scaffolding that learning as well. So yeah, fabulous.
Yeah.
Carrie Ann, that is like such an important word, because I think sometimes because curriculum in higher education is so jam-packed, we don't really scaffold and take a skill and then put it in context of, well, what does it look like in, maternal child health? What does it look like in acute care? What does it look like in community care? And we forget to scaffold it in different contexts and make it, more complex, more nuances. And that's what I think really helps people be ready for practice.
Yeah. I know, Kate, that we've spoken
I
of, yeah, go, Kerry. So
sorry, I think there's a real risk of when we get caught up with skill sets where students are actually in a simulation lab practicing actual tasks,
Mhm.
where sometimes those tasks can be quite simplistic. That I've often said to students, I could actually teach primary school children these skills. There is nothing really difficult about it. But what separates you from a primary school child to a registered nurse? It is about that critical thinking. It is about that next layer. And so I really love that whole concept. Recently where I'm working, we're doing this I do, we do, you do approach in the simulation context, where we're seeing students progress through that task, but then starting to overlay. Now, unless you are in a curriculum where you can see what is happening in other units, you can often lose that scaffolding. You can often see that
Mhm.
skills just get repeated, or they
Yeah.
remain at a basic level without adding that layer of complexity, where we bring in the clinical reasoning, where we bring in that critical thinking. So I really love this. And, potentially how this could be transparent in a curriculum, so that other unit coordinators in courses can see what is happening in this unit, what then needs to be brought into this next unit. I just love that scaffold
Mm.
approach that this can bring.
Mhm.
Yeah, thanks, Kerry.
Yeah, go ahead, Mel.
I'm going to jump to you soon, but I think that whole transparency. So one thing we've done where I work is each sim lead in each discipline, I've asked them to matrix their simulation-based curriculum and matrix them to the sim zones. And so everyone can see within their own discipline what simulation is occurring across curriculum and across the years, and what sim zone it is. And so it really
Mhm.
allows you to see, well, over 1 year, are we increasing in complexity, let alone over the 3-year course, are we increasing in complexity? And overwhelmingly, I know we found that in one discipline, it was basically majority was zone 1. And so, then it's around, okay, well, what are we doing to be experts then in zone 1? Like, are we all teaching the same? Are we all using an evidence-based framework to teach skills? Are we all
There's
know how to give action-orientated feedback? Are we? And the answer was no. So that's the
Mhm.
work that you can really target and
Mhm.
improve how we deliver curriculum using
Yeah.
the zones. But I've kind of jumped ahead because, Kate, I think we've jumped over the bridge, but just to bring it back, what are the key differences using the sim zones in higher ed to health-based sim?
Sure. And listen, I think that this is still a work in progress as we apply it in the higher education model. And I think zone zero is zone zero. What has to stay in front of that is requisite knowledge, because in the professional side, there's a reasonable assumption people have passed board exams and those kinds of things, so they come with some requisite knowledge. But we're oftentimes, that's a core piece of what we do, particularly in undergrad, and then as people are transitioning to advanced practice. So requisite knowledge, zone zero remains an automated feedback that we may not be there in the moment, but we've designed the learning activity where they get to apply and get automated feedback. And I think that the zone one, oftentimes I think of our fundamental labs and our skill labs in all health professions. And the shift is recognizing the sometimes occasional magical thinking that if we've taught it in a fundamental lab, they all, they've mastered it, and they haven't, because they're not at mastery then. They're just developing, and they might be able to demonstrate in a lab context, but it's not competence. And I think we're learning, particularly in the States, as we sort of wrestle with competency-based curriculum, that they may have the skill, which is a skill checklist, but they might not have, as Carrie Ann talked about, like the knowledge and the attitudes to go around that. Like, when would you put a Foley catheter in versus a straight cath? What concerns do you have about this particular patient based on their medical history and their anatomy and all those kinds of things? And that doesn't happen in fundamentals. And then zone 2 for us in academia, I have to say we have become so enamored with the role of pause and discuss in zone 2. And I know this like gives Chris shivers because we're like, well, it's an early zone 2, because their cognitive load when they come into the sim lab is so high. When you put them in and they're seeing a patient and the patient is telling them what's going on, the beeps and whistles, the alarms are going off. And even if they have the right answer, their cognitive load's so high, they can't access that thinking. But you pause the sim, you come in as faculty and you say to them, so what are you noticing? And they're like, blah, blah, and they're telling you all this great thing. And you're like, that's fantastic. And they will say to you, but I was stuck. But now when all that contextual nose goes away, you can either like massage their thinking a little bit or amplify that they're on the right path, keep going, continue on. And now I'm going to turn on all those contextual elements again. But that pause and that coaching, deliberate coaching, I think is so powerful for them. And in many ways, in my mind, reflects clinical life, because I would never left my students by themselves in a complex situation. Like, I'd let them go so far and then I'd be like, okay, like, what's going on? What are you thinking? But I would never like let them do it. So that zone 2, I think, is very powerful for us. And we really, under our undergrad, only have one, what I would consider a zone 3 simulation, which is a disaster simulation. And we still have a coach in the room, which is one of us as an embedded charge nurse that's there to coach. And we might coach more heavily if they're sort of struggling, and we might coach a little lighter if they're doing really well. But they always have that sort of security of someone. So they're not in there all by themselves. I think where we struggle and where we want, like, what's our really big opportunity is that zone 3 around interprofessional conversations, um, which is challenging. And then zone 4 is, in my mind, in higher education, is clinical practice.
So I want to touch on that soon, because I know we've had lots of discussions around that. And I've got an example of what I think sim-based zone 4 is. But before we jump to that, Mary, can you help us explain one thing I really like about SimZones, because it helps kind of guide the faculty on what kind of feedback or conversations and when, like, what is the difference between feedback coaching and debriefing, which could be its own session in itself. But can you help explain that?
Yeah. So, and Mel, as you know, Kate and I were authors on a paper that talks about teaching, coaching, and debriefing with good judgment. So, taking those strategies of teaching versus coaching versus debriefing, and embedding the with good judgment values in that, with good judgment being the method of debriefing taught at the Center for Medical Simulation. All right. Now I've already lost track of your original question. It's like, what are the differences? What are the differences between these?
And when, kind of, you might
and
pull
when.
that out
And
of
so
your bag.
again, here's where SimZones really helps us. Zone 1, like, super clear what the learners are expected to do, very limited in like how much of that extra critical thinking goes on around it. And the instructor's stance in zone 1 is a stance of understanding that the learners just don't know how to do this thing, and that's why they're there. So you give them some zone 0 learning before they come to the lab, and then when they're there in the lab, you're just going to tell them what to do. So when you see them struggling with whatever, you know how nursing students are with getting the Foley catheter kits open and everything sterile, That is not the time for the instructor to stand there and go, so look at what you're doing. What are you doing wrong? Because how would they know? So this is the time to go,
Okay.
stop, look at your hand. Your bare hand is touching what needs to be sterile. Do you see that? Yes. Okay, back up a couple steps. Let's do it again. That's zone 1.
Yeah.
Zone 2 is where we move into coaching. And the difference between a teacher and a coach is when you're teaching, everybody kind of gets the same thing because they're all at ground zero, right?
Mhm.
But they all leave zone 1 with a sort of a baseline level of skill. But in zone 2, this is where individual idiosyncrasies start to pop up. Let's stick with our Foley. So in zone 2, there may be some students who still struggle with sterile technique. Okay, then we're going to coach them on that. There may be other students, they got that sterile technique down pat, but they do not know how to talk to patients. So we need to coach those students on that. And so coaching is very much dealing with those idiosyncratic challenges that come up as people's skills start to develop. And when you're in a coaching context, it is still really important to be super clear with what's going on with the learner. Hey, I see you opening the Foley catheter kit and putting things on non-sterile surfaces. I'm really concerned that the patient is going to end up with urinary tract infection if you do this. Here's what I think would work better for you. Make a suggestion and then say to the learner, how does that sound? Do you think you can do that? Check in with them if they're on the same page. Yes. Okay, back up and do it again. Anytime you're coaching, having your students redo after they get the feedback is super important because I can tell them what to do and go, does that make sense to you? And they'll be like, yeah, Dr. Faye, that's great. And they have no idea what I'm talking about. So we always want to give them a chance to do it again. So that's coaching. And then debriefing is more of an exploratory conversation. What were the challenges? What made this hard for you? What were you trying to accomplish and how did you get derailed? So it's a little more, in my mind, like a little more of an abstract conversation when we're debriefing because now we're really exploring team dynamics, individual dynamics, biases, prejudices, what we saw, what we didn't see. So it's more kind of open as opposed to teaching and coaching where I'm trying to like accomplish one thing. Debriefing's a little looser, I guess, is a word for debriefing.
Okay.
But, I think it is super important to point up, and Kate and I have had this conversation with Chris many times. There's really not a super bright line, especially between zone 2 and zone 3. So Kate and I are always kidding saying, oh, there's a zone 2.5 because sometimes you think you're moving into a zone 3 sim, but you get there and you find out that your learners are still struggling with a more fundamental aspect of whatever the challenge is. And you need to sort of back up and do a little bit of coaching. That's totally fine. Sometimes you're in a zone 2 and you're like, oh, gosh, they totally missed this. I need to back up and do a little bit of zone 1 practice before I can confidently move them into zone 2. And so there's not always a bright line and it's not always forward progress. Sometimes you realize because of the learners you have with you, you need to back up and do a little touch on a previous zone just to get everybody ready to go.
Thank you. Kate.
I love how Mary's describing that. And I often think and talk to faculty about the idea of you're scheduled, you think you're doing a little bit of a zone 2 sim. So you're going to be coaching. And you coach, and the learner is not able to sort of course correct. And to me, then like my little internal rule in my head is if I've said something a couple of times, then I'm coaching on the wrong thing. Like either I'm making a judgment about what might be getting in their way in that zone, and I'm coaching and saying, "Look, don't do this, and here's why." So I'm giving directed coaching, but they're not doing it. So there's, something that they're seeing. So then that's where I see those faculty, particularly in clinical practice, who are out with the learners in real life, being able to go, okay, I've coached you twice. We're sort of stuck in the same loop. I help me understand what's going on here for you because I'm coaching you on the wrong thing. So I see like this sort of nuanced when in expert faculty practice of being able to go, okay, coaching is not working. It's not about the learner, it's about how I'm coaching. So now I'm going to explore to try and understand and better target my coaching to help you get better. Whereas I think historically we might sort of start that, ladder of inference going, well, the learner's not listening, the learner's not going to be able to do this, when in fact we're coaching on the wrong thing, and they're internally going, yeah, I know that piece. I'm stuck over here,
Yeah.
but they're not being able to articulate that. So I think that's like, to me, that was a big shift for me to be able to go, oh, wait a minute, I've coached and it's not working. I need to figure out what's going on here. Easy to say, hard to do, for
Yeah.
all of us, because you sort of get caught in that coaching loop.
But that's such an important point. Like, you take it out of the sim lab and look about feedback in general. You might give learners feedback, and the behavior isn't changing. So then we do need to switch to an exploratory kind of frames-based approach. Like, what is driving those actions that I'm not seeing, and they might not yet understand.
Right.
Right.
So it may not be that they're just not listening. Yeah.
Yeah. And as an educator, you can get caught in that loop. Why aren't you doing what I tell you?
Yeah.
and if you can't sort of take that breath and go, wait a minute, I must be missing something. And to me, that's the basic assumption, but which, is easy to talk about, but that's when
Yeah.
it really matters, when you can sort of go, okay, wait a minute, I must be missing something here.
Yeah. And I think, Carrie, that might be hard to do when there's 30 students in the class. Like, the cognitive load for you, right? Like, who have I said that to, and when, and how many times? Yeah. I guess that's the support our faculty need. They need training and support and mentorship in that space to get to that
Well,
point.
right. And I'm guessing, Carrie Ann, that in that classroom setting, and if somebody is stuck, like, how much do you work with them to help them get unstuck without
And that's
making them feel like they're, you're sort of not targeting them, but it's potentially uncomfortable for them.
and I think you've hit a pretty important point there, because one of the challenges we face in the Australian context is many faculties have anything from 18 students per one facilitator in a classroom to potentially 32 students with two facilitators. Now, the challenge also lies in the fact that many of our classroom lab spaces may have clinicians that are coming in overseeing the students who may not necessarily be au fait with some of the principles around simulation. So it might be that one person who is experienced in simulation working with another less experienced clinician who's come in because of their expertise in the clinical side of things, but not necessarily the teaching side of things. So herein lies a challenge. And how is it that you move past that? These are ongoing challenges for us in simulation in the Australian context. I'm speaking from my experience, not necessarily everyone else's, but
no, I think it's
Pretty
generic.
universal.
Yeah. All right. Thank you for that. Such an important discussion. And I think, one that needs to continue to happen, I think. And hopefully, people listening to this, it may trigger conversations within their own organizations and faculty. I would love to.
And Mel, I think
I'll go, Kerry.
Sorry, just one more thing. I think this is a really great opportunity for us to be thinking about when we're catering for clinical laboratory situations where we've got clinicians in there and perhaps a more experienced academic, of how we can establish frameworks that make it a KISS approach, keep it simple approach, even though there's complexities in it. But if we remove almost the difficulty in what people perceive as what simulation is, which often moves them away from actually participating in sim because they think, I'm going to miss this. And I remember even the early days of being introduced into debrief thinking, oh my gosh, that is so hard. There are so many elements to debrief. I don't think I'm going to be able to do it. But then someone gives you an overlay of a framework that, hey, just do it like this. So I'm thinking in these sim zones, how great it would be to have some sort of framework that allows us to see it really transparently in curriculum, that it's not too hard, and again, I want to push that opportunity for our listeners to think, have a go, look at things in a simplistic way that can make a difference for our learners. Yeah.
Carrie Ann, I think that the teaching, coaching, and debriefing with good judgment paper, we tried to keep it really practical. And that actually gives like examples of what a conversation might sound like in each zone. And so that might be something that you might find helpful. And I would also say that, I don't know to what degree this is possible there, but I certainly advocate for this in the US, that anybody who's teaching our learners in simulation, they've got to have some kind of orientation to how this all works. Or else what we end up with is clinicians who are coming into the lab and they don't feel confident in what they're being asked to do. And I think many times people who have the potential to be great teachers sometimes get discouraged early on because we throw them into situations that they're not ready for. So let's think about what zone 1, zone 0, zone 2 training for clinical adjuncts that might be coming in to help us. And it doesn't have to be extensive.
Yes. And herein lies a major difference in that in Australian context, again, I'm only speaking from my experience, we do not need to have simulation qualification to be teaching inside a simulation context. So, how are we preparing our educators with those principles? And the other challenge lies in the casualisation of staff.
Yes.
And, that you're bringing in staff members here for one semester and then they're off.
Yeah.
And then they're often being employed from the point of week 1 without necessarily that time to prepare them. So we have challenges that I think this probably echoes for many academics across the country and maybe the US.
In the world.
Kate.
Yeah, I would, Carrie Ann, I think that's a universal challenge of, the constant dilemma or tension is time. Everyone's busy, everyone's teaching a lot of credits. The what you call casual, we would mostly call adjuncts or clinical faculty. They're hired just, kind of a just in time approach. And part of that hire is not a week of orientation.
Right.
So how do we provide that, like zone 0, zone 1 training, at least a little bit of zone 2 where they're getting some feedback and coaching from an expert to help them feel comfortable and kind of develop their own style and think about how does that sound like them, because they're going to sound different to whoever's coaching them. I think that's a real tension, and legitimizing that teaching in simulation is different. It's a different skill set.
Yeah.
Yeah.
I think one way I've tried to tackle this is, yes, get each discipline to kind of matrix a simulation in their curricula. Then we can see where different units lie in the SimZones. And then I kind of created a SimZone kind of faculty development plan, looking at what are the kind of modes and modalities and methods of sim used in that zone. What tools in an organization we have that they need to get orientated to. And then what are some faculty development activities we could do? So, for example, zone 0, independent practice, the skills really is around kind of how do we, I guess it's a technical kind of zone where you might use independent CPR mannequins or VR headsets or things like that. We also have at my organization Sim Capture for Skills, so students can independently film their practice and do peer-to-peer assessment or self-assessment. And so then what are the relevant faculty development? Well, it's around, I guess, orientation and familiarization to these technologies, ensuring they know how to operate it and they know how to pre-brief it and provide feedback. So then you go into zone 1 and it's around task trainers or, mannequins, online scenarios, again, virtual reality. We have simulated EMR as part of the tools, Sim Capture for Skills, virtual reality, and these part task trainers. So do the faculty know how to manage those resources, how to design and deliver skills-based Zone 1 activities? Do they know how to teach a skill using an evidence-based framework like Peyton's? Do they know the difference of the type of feedback? Is it feedback? Is it coaching? How do they manage those feedback conversations? How do they pre-brief and maintain psychological safety for technical skills? And then you can go up through the zone. So it really helps you map and think. And if in this particular unit, you're focused on zone 2, well, then you need to focus your faculty development on zone 2. Don't worry about all the rest. Just get them good at that zone, but have an understanding of the prior zones. So it really helps you prioritize what faculty in what unit at what level in the curricula needs what training. And it makes something that's quite overwhelming, I think, down to bite-sized pieces.
Right. Yeah.
I love that. And I think I don't know if we've like sort of morphed into one human being, Mel, but that's where we've gotten to proposal wise, because I had a proposal for faculty development that was sort of all encompassing, and they're like, "Yeah, that's lovely. It's never going to work." People can't. So we did. Okay, so if you're going to be if you're going to be a Zone 1 faculty, and that's where you live, then we're going to teach you. So we've sort of made it modular so that people can, depending on where you teach, you would then access those skills and attend that faculty development. And I think it's a pretty similar approach I love your deliberateness in matrixing and I think that is so revealing for faculty. Oh, because they don't often get to like have that pause and actually really reflect on, where am I teaching? What's my priorities here? Because I think people are, so busy that gives them that opportunity. So I love that you've done that. And I think that's the right approach, is that module. Everybody's not going to be good at everything.
Yeah.
Because if they just live in one space and, Zone 1 is simulation, then be a fabulous Zone 1 simulationist. Yeah.
Yeah.
I love that.
Great. So I thought I might, because this may generate some conversation, particularly as we go up the zones. I would love to give an example from occupational therapy. They do an immersive simulation week that is actually their clinical placement. So they do this particular placement in simulation. And so over the course of the week, they do different activities, which hopefully scaffold up to the summative assessment. So I thought it would also be a good example of maybe what different things look like in the zones. So for Zone 0, they do classroom content at the start of the week. So what they do is they watch a client interview on a video, and then in class evaluate that performance and complete their own kind of reflective exercise on what they saw, maybe identify their own learning needs, where the gaps were. So that's kind of that prerequisite knowledge. Then Zone 1 is peer-to-peer practice with feedback, using their summative assessment rubric to guide the feedback conversations. So it's still formative assessment. So they do a client interview peer-to-peer and do documentation of that interview, and they practice a phone call to a physician to report the assessment findings. So they're assessed on really professional behaviour, self-management, communication, effective information gathering, and identification of the client's needs. So this is kind of more feedback coaching. And then in Zone 2, which is around Wednesday, they bring in paid actors as simulated participants, And so now they do these interview rehearsals with the SPs, with immediate faculty and SP feedback via like a mini debrief. And then they rewatch a video of their own performance and self-reflect. So again, reflect against the summative assessment items. Now, zone 3, and I love your thoughts if this is zone 3, but they do a student-led mini case conference where they discuss the client's interview results and they collectively think about a proposed rehabilitation plan that needs to involve other health professionals. And then they get feedback and coaching on that discussion. And then zone 5, and this is where Chris and I may differ in opinion. Zone 4 is high. They do a high stakes assessment, simulation based assessment. Now, high stakes being they use the exact same assessment rubric as what they would out on clinical placement. So it's no different. And they must pass this assessment as they would a clinical placement to continue on in the course. So for all intents and purposes, it is their placement. They get summative assessed with the placement tool. So I know in the original SimZones for the healthcare context, it is in the real world environment. Here they can't do placement in the real world environment for a number of reasons. So they've had to simulate it, and it is their placement. Thoughts?
So, I'm going to say that my initial reaction is something that I had to come around to, which is just because the numbers are higher doesn't mean it's better. And what I mean by that is we always think that it always has to go zone 0, zone 1, zone 2, zone 3, zone 4, or else we didn't do the whole thing. Not true. Anybody who is a pre-licensure student rarely does a zone 3. Rarely, because zone 3 is really about people who know how to do the skill. And now we're exploring what are the challenges. It's for the experienced ED team who does a resuscitation. Well, they know how to do resuscitations, but in this particular sim, there were particular challenges, and now we explore those challenges. So the big difference between zone 2 and zone 3 is in zone 2, there is an absolute, you did it right, you did it wrong. In zone 3, it's, well, it wasn't exactly what we were looking for. What got in your way? So there's a difference between those two. And so I'm going to say that what you called a zone 3 isn't. It's a zone 2.5. and I'm with Chris. Zone 4 is applied learning in the real workplace. So even though you're using exactly the same rubric, I don't think that makes that a zone 4. Now, having said that, I'm dying to know what Kate's going to say, because the zones is a theory. It's a framework. It's not black and white, so everything I just said comes from my understanding of the SimZones and how it gets applied. And we are very much still exploring what this means in the academic space.
So in zone 2, what is different then to zone 3 of just doing a frames-based debrief that's focusing on behaviors and attitudes and teamwork as opposed to skill?
I think it comes down to zone 3 is really intended for experienced clinicians who really don't need to buff up their skills a whole lot. They just need to explore the challenges in a given situation. Whereas a zone 2, people are still they're not super expert with their skills, and there's a right way and a wrong way to do it. And we are still in the role in a zone 2 of observing them to see if they got it right or got it wrong. And in zone 3, it's a little bit different.
It's grayer. Yeah.
It's grayer. But this is why there's a 2.5.
Right. And that's why I think there's gradations in zone 2. And a lot of what we do in the undergraduate world doesn't ever really get beyond zone 2. And I think about our disaster sim, which has ethical dilemmas around, do you continue doing CPR on someone, in a disaster? They're in the emergency room. So, they would have been black tagged if they were in the field, and do you really put these? So there's not really a right or wrong. You can argue both sides of the fence around the ethical dilemmas of, resuscitating, not resuscitating. And I think that's a little grayer. And to me, that is like a 2.75 because we got a coach in the room. Like we're not good. I know, which is just, but Chris is like having all of a sudden a migraine because they can't always. And oftentimes we coach them to stop, and by asking provocative questions of, how long have you been doing this? I'm worried about the resources. You got 4 people here. You got more patients coming in. So like we're pushing them to make a decision, and sometimes we're making the decision for them. Versus at the graduate level, I think about the zone. I think about the zone 3 we do with them around an impaired colleague, and they're already professional nurses. They're experienced ICU nurses who are back learning how to be nurse anesthetists. And yet this impaired colleague thing is it's hard. There's not, do you, don't you, when do you, what are the signs, symptoms, where's patient safety, where's professional response? It's a little more nuanced than um
And
the
like the field, you gave the right drug at the right time.
right, like
Yeah.
that's yeah, like here's the dose, don't give 10 milligrams of morphine, people aren't going to breathe. So I think that becomes the struggle. And I think we've gone around and around trying to think about, like, zone 4 for us in higher education is clinical practice. And I know, Mary, you've coached me around the like the safety guards are different in clinical practice than they are in simulation. Even if you're holding them to the same rubric, we don't have the same safety rails in simulation that have to exist in clinical practice. Like when you coached me around that, I was like, yeah, I can see that. Like
Very
I might take that clinical person and say, hey, you need some more coaching based on what
yes.
happened in sim, but nothing bad's gonna happen if they make a med error.
Yeah.
How are we
Interesting.
doing, Mallory? Are we helping make that make sense in your
It's
mind?
hard.
No,
Yeah,
I'm
we've
getting there.
conversations about this. Yeah.
Yeah, I'm getting there. It's so zone 2 can be high stakes.
Oh,
Some of
absolutely.
the yeah.
Sure.
Yeah.
Absolutely.
Yeah.
Excellent.
Yeah.
And I think of zone 4 as real clinicians solving clinical problems.
Mhm.
Like, for example, hey, we had a resuscitation, all these things didn't go so well, and now they're solving that clinical problem that happened in real life. And Mary, course correct me if
Yeah.
I'm like off in la la land. And they might then use simulation to solve that problem, but they're focused on solving clinical problems. And when our students are out in clinical, the stakes are certainly higher. And yet, and this may be a difference in the States, they're not left to their own devices.
Mm.
There's always going to be a clinical faculty supervising them, particularly
Yeah.
at the undergrad level. And at the graduate level, it would be a preceptor.
Yeah. And I think back to your point, the zones go both ways. So I think what I'd like to see in zone 4 in real clinical practice is our facilitators getting taught how to do frames-based debriefing and coaching, because often if someone fails a skill, if they've passed that skill in uni, it's not often the actual technical skill that they're unable to do in real clinical practice. It's all the context and everything
All the other stuff. Right.
around
Right.
it. And so sending them back to uni to redo the competency is not fixing the right thing.
Right.
And it would
Right.
save a whole lot of work and paperwork in learning plans if we knew how to explore and understand what was going on for that learner in that moment and in that context. It's not always knowledge and technical skill.
Yeah.
Yeah, 100% agree. And I think about the power of um, what we would call post conference, which those debriefing tools of being able to facilitate and dive in deeper around things that happened and understanding what might have got in the way of that learner
Yeah.
of being able to demonstrate, what we've determined is the right thing, or expanding their thinking around generalizing and applying of, well, what if it was in this slightly different context? Would that change what you did? Would that change your approach? What if the cultural context was different? Would that change what you did with that patient? And how, sort of that challenging reflection piece, like, to me, I think we don't always consistently leverage those
Yeah.
post-conference conversations in a way that could help people.
Agree.
Yeah, and I think that highlights that, all of this thinking around what stage is my learner at and how do I facilitate this learning experience, that belongs everywhere, not just in the simulation lab. And when you're talking about like zone 1 simulations, Mel, they don't have to happen in a sim lab. They can happen in a classroom. You
Yeah.
think about teaching therapeutic communication or
Mhm.
SBAR. You can do zone 1, zone 2 in a classroom.
Anywhere.
Yeah,
Yeah.
yeah. And so I think all facilitators in an ideal world, would be skilled in facilitating learning conversations across the continuum.
Excellent. Well, an amazing discussion, and we could keep going, but I think we've the cognitive load of us and our listeners in view and respect of constructivism, we might pause there. But super interesting conversation, and yeah, more discussions to have, particularly in the higher education context. And I know,
Mhm.
we're thinking
Mhm.
about
Yeah.
trying to put something out to support SimZones in that context. So watch this space, hopefully. But thank you all. Thank you, Carrie. Thank you, Mary. Thank you,
Thank
Kate.
you.
Great to
And
see you guys.
Thanks,
hopefully
Mel.
we'll get to have happy hour in person one
Real
day.
happy hour.
Yeah.
We'll
Excellent.
come to you.
Brilliant.
Yeah.
The bubbles are on me.
Thanks, Mel.
Excellent.
Great to see you again, Carrie Ann.
Likewise.
Thank
Cheers,
you.
guys.
Bye.
Thank you, guys.